Noakowski, aye.
9-0, that
Out.
bill is out. Thank you very much, Senator Galgiani, for doing that
you.
for Senator Runner. And now we will move back to your item number 7, SB 1177.
Thank you, Mr. Chair and members. SB 1177 would create a physician health and wellness program to treat and rehabilitate those who suffer from substance abuse disorders. I want to begin by accepting the proposed amendments listed in the committee analysis and thank the chair and committee staff for their time and efforts on the language to ensure we create both sufficient consumer protections and an effective treatment program for physicians. Currently, California physicians and surgeons regulated by the medical board are the only licensed medical professionals without a wellness and treatment program. In fact, California is just one of a few states nationwide that does not provide such a program. Without a program in our state, physicians and surgeons who suffer from these conditions often do not know where to turn for help. From 1980 until 2007, the Medical Board of California operated a diversion program for physicians and surgeons. That program allowed for participation in the program in lieu of discipline. The program proposed under my bill, SB 1177, as amended, would not be a diversion program. Rather, participation would not preclude the board from taking disciplinary actions deemed necessary, thereby strengthening consumer protections. Instead of the board itself running the program, SB 1177 would allow the board to contract with a private third party to administer the health and wellness program. Additional protections have been built in to ensure informative and regular communication between the program and board, and that the board is notified if a participant withdraws or terminates from the program. This includes physicians and surgeons who voluntarily self-refer to the program, which provides much greater consumer protections. This bill would bring California back in line with the majority of other states and licensed professions who recognize that wellness and treatment programs serve to enhance public health as well as provide necessary resources for those in need of help. Again, amendments that enhance consumer protections have been taken, including complying with the uniform standards regarding substance abuse healing arts licensees that are found in other wellness programs currently operating in the state. I will now turn it over to the supporters of the bill. Thank you.
Thank you, Senator Galgiani. Witnesses in support.
Chair Hill and members of the committee, thank you for the opportunity to testify before you. My name is Dr. David Kahn, and I'm the president-elect of the California Society of Addiction Medicine. It's a physician organization of over 400 physicians dedicated to the practice of addiction medicine and the treatment of substance use disorders. I'm here to tell you today that Senate Bill 1177 will create a much-needed statewide physician health and wellness program, which is essential for the early identification of physicians with addictive disorders. It will be a resource where physicians can be referred to for treatment referrals and will monitor those physicians to ensure public safety. Many other professions in the state have these programs in place. Doctors of osteopathic medicine, DOs, nurses, dentists, pharmacists, and attorneys, just to name a few. Yet allopathic physicians have no options available even when they face the same illnesses. Physician health programs enhance early detection, potentially impairing illness, with documented long-term maintenance of remission with successful outcomes. It has been determined that safety-sensitive workers do best when offered cohort-specific treatments at facilities that specialize in with specialized experience in treating healthcare professionals. Such treatment has been demonstrated in the evidence to improve outcomes for physicians and the prognosis. Addiction has been recognized as a chronic disease for over 50 years. It responds equally well to treatment, just like other chronic diseases. Unlike other chronic diseases, however, addiction carries denial and stigma, and this prevents people from getting the treatment that they need. Physicians who suffer from substance use disorders need to break through that denial and stigma in order to succeed in treatment. And this program would provide that doorway that they can get the help that they need. To protect patient safety, the American Medical Association recommends that all states provide medical treatments along with monitoring for healthcare professionals with substance use problems. The MA recommends Programs such as the one proposed here that include assessment, screening, referral to treatment, case managing, monitoring, all delivered in a supportive environment, so healthcare providers will be encouraged to seek help at the earliest sign of need. California needs a statewide program where physicians and those who are trying to intervene with physicians can get the help that they need. I want to share with you 4 facts about the program. Number 1, there will be no cost to the state or to taxpayers. It is paid for by the participants themselves. Number 2, anyone can call the program and get help from the program in approaching and intervening with a physician where there's a matter of concern. Anyone. Number 3, doctors with these disorders, just like anybody else, will not come forward to get treatment or will come forward to access the program unless the program is kept confidential. The names and identities of program participants shall remain confidential unless the participant is not meeting the requirements and conditions of their treatment agreement or they enter the program as a condition of probation, board action, or are subject to current investigation. And the 4th, there are many safeguards that exist in physician health programs, and none of these safeguards now exist in a coordinated manner without such a program. In short, depending on the area that you're in, whether it's rural, urban, or mixed, you have different access to different types of treatments. To protect our patients, we must find the most effective way to shield them from healthcare professionals who are impaired by their abuse of alcohol or other drugs. A well-designed system of assessment, early intervention, treatment, and monitoring will be of the greatest benefit to Californians. A system based on punishment only will only cause those who need the help to hide their problems. And this environment creates a greater threat to the health and safety of California healthcare consumers. This is why I'm here today seeking your support for Senate Bill 1177 and your support of protecting the public by creating an effective physician health and wellness program for the state of California. Thank you.
Thank you. Others in support?
Janice Norman on behalf of the California Medical Association, recognizing the late hour. Just want to thank the chair for working so diligently with ourselves and the author to put forth a product that I think is stronger and provide than existing practice and provides really good protections, not only for the patients, but for those physicians that have an illness that hasn't reached the impairment stage, that they are able to seek the care that they rightfully need, and here to answer any questions.
Thank you, Mr. Norman. Others in support?
Mr. Chairman, members of the committee, Randall Hager, representing the California Psychiatric Association. We're here to urge your support for this very important bill.
Thank you very much. Others in support?
Hi, I'm Jennifer Simoes with the Medical Board of California. The board has not actually taken a position on this bill, but the board did approve elements of a physician health program that the board could support at its October 2015 board meeting. The board staff would like to thank the committee staff for working so diligently on this bill. And with the amendments, the board staff believes that they do comply with the board-approved elements, and we'll be taking this bill to our next board meeting in May. Thank you.
Thank you.
Hi, good afternoon, Mr. Chair and members. Connie Delgado with the California Hospital Association. We are in support of this bill and believe it will really help with protecting the patients and the public.
Thank you very much, Ms. Delgado.
And Jody Hicks with the California Academy of Family Physicians in support.
Very good. Thank you, Ms. Hicks. Others in support? Seeing no one, those in opposition, please come forward. And maybe if... You know, you sit right there. Okay, Mr. Howard.
Mr. Chair and members, good evening. Ed Howard with the Center for Public Interest Law, respectfully rising in opposition to the bill. There are a number of issues that we have with the drafting of the bill that I'll highlight, hopefully briefly, in just a moment. I did want to start off with a big picture reason why we're so adamant about making sure that the drafting of this bill is beyond question protective of patients. And that is that the reason why the medical board no longer has a diversion program is because it failed not one audit, not 2 audits, not 3 audits, not 4 audits, but 5. And the audits were so bad and so stubbornly bad that the medical board itself voted unanimously to end the last program, especially as, even at its height, it only saw about 300 or less physicians at any given time, a tiny fraction of the physicians estimated to be struggling with drug and alcohol addiction. The second is we do respectfully take issue with the question that there are no other options for drug and alcohol addicted physicians. That simply isn't correct. There are innumerable private options and clinics, as well as licensed professionals, who are ready, willing, and able, and fully competent to be able to treat all people who have drug and alcohol addiction, including doctors. And there has never been, whether it's with this program or any other, the case where there has been a needs assessment to make sure that the private market is not adequately already taking care of this problem. The third, and this is the biggest one, the third is that while there are many, many places where the interests of drug and alcohol addicted people should be paramount, i.e. in any therapist patient relationship, there is only one place, and there must be only one place, where the interests of patients are the only thing that are at stake. Only one place. We can't have a medical board that places the interests of patients first just sometimes. In every program that is under the aegis of the medical board, including this one, the interests of patients, if they might conflict, even with the sincere effort to try and provide a therapy for a drug and alcohol addicted doctor, must yield to the interest of patients. So with that in mind, we have in the past never opposed any kind of program that might actually help drug and alcohol addicted doctors. For example, maybe more rigorous scrutiny and licensing of those clinics out there that already provide it. But we have had 4 requirements over the last several iterations of this bill, which we think are the baseline ones for protecting patients. The first is that it not divert. And as the senator correctly mentioned, this bill does not. The second is that it adhere to the standards that this particular committee authored and has been really the guardian of since Senator Ridley Thomas held your chair, Mr. Chairman. And that is that the operations of the programs unambiguously, without question, comply with the uniform standards. And what those uniform standards do is they make sure that the mistakes of the past can't be repeated. They make sure that drug and alcohol addicted doctors, who not only have life and death over all of us, but who also have simultaneously access to among the most addictive narcotics known to man, they are treated in such a fashion so as to elevate the needs of patients first. And if there is any ambiguity, we would respectfully ask that that be clarified. The third is that there be immediate notification of any doctor who has a problem, because this is a program of the medical board. And then finally, that regardless of who may get the contract, that the individuals who oversaw the program during the 1, 2, 3, 4, 5 failed audits not be among the people who will ever be able to run this program again. So on those 4 lists, diversion, check. The 1441 standards, the bill respectfully is unclear when it comes to its drafting, and if it is the intent of the author and the chair in working on this, then if that's true, that the 1441 standards are supposed to apply no matter to which patient, we'll be offering please some clarifying amendments that I think that would make that abundantly clear, because right now, for the reasons we outline in our letter, and I will not outline for you right now, that is respectfully not clear. And it's not just our analysis of that, it's the analysis of the other consumer groups as well. That relates to the immediate notification, whether or not patients will be protected by the medical board being made aware of physicians who are treating them, who are currently failing drug tests or failing to show up for their group therapies or whatever, or whether or not the hospital who is working with this physician is notified of those things. That also is dealt with in the uniform standards. And if the uniform standards clearly apply, then our concern there will evaporate. And then finally, the last issue is that the same people not be able to run this program again. It is true that in prior iterations of this bill, there were more, let us say, conditions on the awardee that don't exist in this bill, and for that we want to thank the senator. But it also must be the case that if we are going to prevent the mistakes of the past from existing again, and if this is really about patient protection, then there'll be specific language as a part of the RFP that prevents the same individuals from running this program who ran it into the ground before. With that, I'm pleased to take any questions you may have, Mr. Chairman or members, and thank you for your time.
Thank you, Mr. Howard. Seeing no questions now. Yes, hi, Tina.
Good afternoon, Senator Hill and members of the committee. My name is Tina Manassian. I'm a survivor and a victim of medical harm caused by a doctor whose substance abuse was kept hidden from me and countless others due to his participation in the medical board's now defunct confidential diversion program. In 2002, Dr. Brian West performed a surgery on me that I was not a candidate for. 4 months after my surgery, he closed his practice down and abandoned me. Nearly 14 years after my botched surgery, I still suffer with excruciating pain, spitting sutures, gaping holes, disfigurement, and a mutilated body. I will be forever reminded of the harm this doctor caused me and how the Medical Board of California didn't protect me. I am fortunate to be here today to tell my story. I know many other patients who were victims of the same physician while he was in diversion. In fact, some have died. Our doctor has had multiple DUI, including one on his way to treat the late Becky Anderson, and was arrested on a DUI car accident. Last week, Michelle Montserrat Ramos was here to testify before you about the death of her fiancé, Lloyd Montserrat, at the hands of another substance abusing physician. If he had the right to know that his doctor was a substance abuse physician, he would be alive today. When Dr. Brian West operated on me, his addiction and his participation in the medical board's diversion program were kept confidential from me and all his other patients. He had multiple chances at diversion. Had this information been available to us, some of these patients might not have died and I wouldn't have been injured. His license was revoked 7 years after my surgery. Last week, Senator Hannah Beth Jackson, you asked, quote, "Who's protecting the patients?" SB 1177 would allow physicians accused of substance abuse to be diverted into a confidential substance abuse program, and that information will be kept secret from the patients. As soon as a physician is required to enter a substance abuse-related program, that information should be publicly reported on the medical board's website. Further, substance abusing physicians who've been referred by the medical board into treatment should be required to disclose that to their patients. The involvement of substance abuse should never be a cause to allow secrecy or reduce public reporting requirements, such as information about actions taken by the board on a doctor's online profiles. The proposed amendments to SB 1177 include half a dozen sometimes conflicting provisions regarding what information must be kept confidential by the medical board. Multiple proposed amendments undermine transparency. For example, 2342F says, quote, "This system shall ensure absolute confidentiality in the communication to the board." While 2343E says, quote, "Any information received, developed, or maintained regarding a physician and a surgeon in the program should not be used for any other purposes." In addition, SB 1177 undermines the uniform standards. In 2008, SB 1441, Mark Ridley Thomas, became law requiring uniform standards for, among others, substance abusing physicians. The uniform standards were finally adopted by the medical board only very recently in July 2015. They set out specific protocols for action regarding physicians who were brought to the medical board's attention for substance abuse. The uniform standards for substance abusing physicians should be given sufficient time to work before putting in place any new system that might interfere with them. There is no need to create a special program that may interfere with the oversight responsibilities of the medical board. Former Medical Board President Richard Fantozzi said, quote, "To hide something from consumers, something so blatant, is unconscionable today." If the Medical Board is not willing to meet its mission to protect California patients, then we look to you to protect your constituents, California voters, California consumers. Additionally, the program included in this legislation for substance abusing physician should not be associated with the California Medical Association or with any nonprofit associated with the CMA or with any entity associated with past administrators. We vote for you. We're asking you, who's protecting the patients? Please vote no today on SB 1177.
Thank you. Others in support? I'm sorry, in opposition.
Thank you. Carmen Balber with the Consumer Watchdog. Last week, this panel voted to get rid of secrecy when it comes to physicians who are placing patients at risk because of their actions. Our fear with this version of this bill is that it continues that kind of secrecy, not just keeping patients in the dark about physician substance abuse, but even the medical board, even the regulators who are there to protect patients. Ed mentioned some of the ambiguities here, and I have to echo that we see the same thing. The language of the bill says the administering entity shall have a system for immediately reporting a physician or surgeon who withdraws or is terminated from the program to the board. So someone who fails out completely or someone who decides to walk away will be reported to the board. What we're afraid is that someone who refuses to show up for a drug test, someone who fails a drug test, someone who doesn't comply with other provisions of their agreement in the treatment program will also not get reported to the board. So if that's not the intent of either the committee or the author with the amendments, we would like some real clarity on that point. I can certainly say that simply identifying termination or withdrawal does not, in a plain reading of the bill, make it clear that any failure to comply with the terms of an agreement would result in reporting to the board. There are other things in the bill that we think are inconsistent with both what the medical board has said they want and also with the broader idea of disclosure, both to patients and to the public. But I will just take one final example of why this disclosure is so important. Tina mentioned the doctor, Brian West, and it was exactly that type of circumstance that we're concerned that someone who does not meet the terms of a program, but continues to practice because they've self-referred themselves into a program and the medical board had nothing to do with it to begin with, continues practicing. And when we have a situation when drunk or high doctors are able to continue practicing, that's a public safety risk. So
I agree.
why we must.
Thank you. Others in opposition?
Hi, good evening. My name is Renee Nielsen, and thank you to Senator Hill and the rest of the committee for allowing me to speak. I'm actually one of your constituents. I am a single mom with 2 high school girls, and I am in opposition to 1177 because of the language that's currently in the bill. And I can't imagine bringing my kids to a physician thinking that things are okay. I work full time and I have plenty on my plate, and it would be, I guess what I'm trying to say is there's too many things going on to have to also worry about going to somebody that you expect to trust. Last week, everybody was in agreement here with the consumer attorneys of California. They voted for common sense consumer protection measures, helping consumers make informed medical decisions. Consumer Watchdog stated every patient deserves to know about their doctor before they receive medical care and notified proactively. Everyone agreed to that. The CFC stated that consumers deserve to feel safe and confident in their medical care, and everyone agreed to that. And the Center for Public Interest Law stated that patients deserve to know critical information. So my feeling is that we just want to be informed consumers and know that we can go to people that we respect and trust. And we know that most doctors are amazing, but it's the ones that aren't that are hiding it. So we really want full transparency. I will tell you that I'm a full-time realtor, and in a real estate transaction, if you're the seller, you're required to disclose every single thing about a property. And then the buyer comes in, and they look at all the disclosures, and they decide if that's okay for them. And then once both parties agree and everyone's happy, then they move forward. It's no different here, except for we're not talking about a house. We're actually talking about our health and our family's safety. And so we really want to know, we really rely on all of you to help look out for our families. I know that there are some actions in place right now that they're considering, and we'd hope that the language is either changed so that there is full transparency and we know that we can rely and trust on the doctors that we go to see. So thank you.
Thank you very much for coming this evening. Appreciate it. Anyone else in opposition? Seeing no one, bring it back to the committee. And Senator Jackson, did you have?
So here's a dilemma. I don't think any of us can find much fault in the testimony of the witnesses who are subjected to bad treatment from doctors who shouldn't have been practicing and who were guilty of committing malpractice, mostly while substance abusers, and there's just no excuse for that. On the other hand, the goal, I think, is to try to get those substance abusers into treatment.
Yes. Those that we don't know about, those who are not under investigation and who are not before the board for any fault while under practice, those who are already in secret that we do not know about, nobody knows about. This is about self-referral.
So, and I think that, and I get that, and I support that notion. I guess my concern is that the level of confidentiality, which you need, I think, is critically important, is also, it's a sword and a shield. And so I'm just wondering how we can get those doctors who need the care, and protect those patients who might be the victims of their, poor medical performance because of that addiction. If you have a thought, I'm very interested in that.
So there is no diversion at all in this bill. There's no diversion from disciplinary action from the board. And also we have language that makes clear that whoever's in the program must comply with the tenets of the program. And we included the Uniform Standards Act. So the opposition raised concern about that, and we did include that specifically. But if someone fails a urine test or they don't show up for a urine test, the goal would be that under the language that we took, where it's required that the physician and surgeon is in compliance with the conditions and procedures in the agreement, that requirement for compliance, it is our intention, would require that they actually show up for the tests and that they do them.
And if I may ask the Medical Association, how do you envision this plan working, and how do you envision it improving upon the past track record?
Yeah, thank you for the question. So two things. One, I think everyone from the Medical Association and the Medical Board has really looked at sort of the past program and thought thoughtfully about the audits and the questions that were raised by the audits. I think that work was partially completed, and I'll tell you why I think partially completed when the Medical Board adopted its principles. And they were really thoughtfully looking at what they had done wrong in the past and how do they put the systems in place to ensure that the errors that occurred in the past don't reoccur. And I think we are picking up on where they left off because clearly they cannot just reestablish the program. They need the authorization to make that happen. And again, so 2 points to that. One, you heard the medical board testify that, or their staff testify that they think we've met all of the principles that they had adopted last fall. And two, the bill is an authorization bill. The bill does not mandate or require the medical board to reestablish the program. It gives them the ability to do so. Just in case the medical board in their review looks at it and there's something that they don't think is right, they don't actually have to follow through. We think we've hit the standards. The medical board staff has said we hit the standards. And so we think we've accomplished that objective. How we think this makes the current situation better. You've heard much testimony or some testimony referring to the fact that there are private organizations that physicians can go to. If you go to a private organization, you are completely confidential. No one in the state knows that you are seeking that kind of care. They know about individuals that are referred to those things through board actions and things of that nature, but no one knows. So therefore, as the physician community is looking at levels of addiction within the general public and trying to have some comparison to whether or not we have identified and are treating the number of physicians dealing with this illness within the profession, because it should be somewhat consistent with the general public. There's no way to evaluate that because all those individuals are in, as the senator said, in hiding in the shadows. So what this bill does is it really smartly looks at how do we bring those individuals out so that the medical community, and more importantly, the medical board, can look and see, are we close to individuals that from a statistical perspective, should be dealing with this illness, this disorder? What do we need to do to increase awareness? What other steps do we need to take? And so there's that aspect of dealing with it. And so from your sword and to go to your other point of your sword and your shield analogy, there's really a spectrum when you're talking about substance abuse disorders, which has been recognized as a chronic illness for a while now. And that spectrum goes from illness to impairment. What we try to make certain of, and absolutely certain of, is if a physician is impaired or even has the hint of impairment, that physician is immediately known to the board, and they do not have that level of confidentiality as someone who is purely dealing with an illness. Because an individual that's purely dealing with an illness, I think everyone would agree, should not be subject to discipline simply for the fact that they're seeking treatment for an illness. What we're trying to capture are the individuals and the physicians that are impaired or have the hint of impairment, which is why the confidentiality in the bill only surrounds a physician that self-refers and is not under a current investigation. Again, a current investigation doesn't mean that the issue is concluded. It simply means that the medical board suspects that there could be something wrong. And we think that once the medical board suspects that there could be something wrong, the confidentiality of the physician participating in that program should be pierced. Because again, in that scenario, there is the hint of impairment, and therefore the right of the necessity of patient safety takes precedent over the confidentiality. So again, based on the testimony that I've heard here today, I think we have met people's standards. I think we've met people's requirements. We can't do anything against individuals having a philosophical disagreement on whether the program should be reestablished or not. All we can do is look at what the audits told us, what the medical boards have told us, and again, working with this wonderful staff and developing something that meets all of that.
Senator Block.
Thank you, Mr. Chair. So if you can just clarify for me then, under this program, a physician is referred to the program, enters the program by self-referral, and is clearly impaired. And at some point, the physician, of his or her own accord, stops attending, drops out of the program. So at that point, is this impaired physician, are patients of this physician then given notice of the physician's impairment?
That information, the way the bill is
I
drafted.
mean, that's an easy yes or no.
Sorry.
Are patients of the impaired physician given notice that the physician is impaired?
That's under Senator Hill's bill. This makes sure that
when a
board
patient,
is notified.
when a patient
The
drops
board is
out,
notified.
when a patient drops out, there's new information you have
I
here.
think the medical board would be advised.
Correct.
And then the medical board gives the information to the
So
patient.
I just want to make sure that I'm being very clear and precise in
Good,
answering
thank
your
you.
question. So the question was, if a individual drops out, does that trigger a patient notification?
Correct.
The answer to that question is no. And the reason the answer to that question is no is because it triggers a medical board notification. The medical board then has the authority to take whatever the appropriate action is to protect patients safely. Therefore, if the medical board issued an allegation, that information would then be posted on the website under existing law. If the individual received probation, again, that information is disclosed on the website under existing law. Under existing law, there isn't a patient notification factors. But, as I think someone hinted to earlier, if that law changes, then the actions of the medical board would change consistent with the law.